Good morning, everyone, or good evening, wherever you are. I'm Norine Walsh, and welcome to our webinar on cardiovascular disease in women, which was organized by JACC Case Reports and the Indonesian Women of Cardiology. I'm from St. Vincent Hospital in Indianapolis, Indiana, in the U.S., and I will be co-chairing this webinar with Dr. Yusra Pintaningrum. And I will turn it over to her.
Okay, thank you, Dr. Walsh and JACC Case Reports for having the Indonesian Women of Cardiology here. We have an incredible faculty line up today to learn from cases and lectures, which will be presented rather rapidly. Myocardial infarction, coronary arteries, and postural orthostatic tachycardia syndrome.
Excellent. So without further ado, we'll go to our first topic. We'll start off with the first case, which will be presented by Dr. Holani Sasmaya from Hasan Kin General Hospital in Bandung, Indonesia. And the first case is on peripartium cardiomyopathy. And this will be followed by a lecture by Dr. Anna Minhas, who's Chief Cardiology Fellow at Johns Hopkins University School of Medicine in Baltimore, Maryland in the USA.
Okay, thank you, Dr. Walsh, and also thank you, JACC Case Report, for the opportunity for me to present a case about subsequent pregnancy in peripartium cardiomyopathy. So the prevalence of PPCM in Indonesia is still unrecovered, but I would like to share one data in Hasan Sadikin General Hospital. As we can see in here, the prevalence is 1 per 350 live births, and there's 9% of PPCM patients that has a subsequent pregnancy. And as we know, there's a lot of fascinating issues to be discussed in peripartium cardiomyopathy, but today I would like to highlight about subsequent pregnancy. So one of my case, Mrs. A, 32 years old, her first presentations was in 14th of May 2017. She is P1A0 2 weeks postpartum with her risk factor was preeclampsia and also obesity. She was diagnosed as PPCM acute heart failure with the preeclampsia. In the laboratory results, we can see high CRP with a slightly high prolactin. The ejection fraction was 34%. She was hospitalized for 7 days. She decided not to breastfeed. We gave her all heart failure medications, and we also gave her bromocriptine 2.5 milligrams for 7 days. And I remember she is the first patient that we gave 7 days regimens of bromocriptines, and we didn't give any anticoagulant for her. So these patients, during the follow-up, in the 6-month follow-up, she was well. The ejection fraction around 38 to 40%, but she's still undecided regarding the contraceptions. We optimizing her medical treatment into sacubitril valsartan because at that moment we don't have a sacubitril valsartan. And then in 1 year follow-up, she was doing great, but unfortunately she was pregnant and already 10 weeks of pregnancy. So we repeat her echo, showed the ejection fraction was improved, but still 48%. So we tried to explain to her and also her family regarding the risk of pregnancy in her conditions. But however, she and her family decided to take the risk and continue the pregnancy. So we need to stop all her heart failure medications except the bisoprolol. We continue the bisoprolol. And then based on the cardiovascular pregnancy team, we treated her as a modified WHO class 4 with a monthly follow-up and then echocardiography. We repeat the echocardiography once in the first trimester and then once in the second trimester and then monthly in the third trimester. In 36 weeks of pregnancy, we repeat the echo, the ejection fraction showed 46%. And then in 38 weeks of pregnancy, the patient was in labor. There's no heart failure sign and symptoms at that moment. We repeat the echocardiography, the ejection fraction showed about 45 to 50%. We perform a vaginal birth with intralabor anesthesia and also assisted delivery. The procedure went well with no complications. We resumed all her heart failure medications. We didn't give any bromocriptine, considering the ejection fraction around 45 and 50%. The patient was hospitalized for 5 days. The long-term plan was contraceptive in 1 month, and then optimizing medical treatment and also follow-up and echocardiography. And the follow-up in the 6 months after subsequent pregnancy, the patient was well, already on IUD contraceptive. The ejection fraction already improved to 56%, so it's considered as a recovery of LV functions. But however, we wanted to continue all her heart failure medications at least for 1 year. And then in 1 year follow-up, we repeat the echo. The ejection fractions was 54%, so it's quite stable. We also did the GLS to this range, which is showed a negative 17.5%, so it's quite good. So we decided to down titrate her heart failure medications gradually every month. In 2 years follow-up, she was great. And then the echo, we repeat again, the ejection fractions around 58%. But however, we just decided to continue the bisoprolol in 2.5 milligrams, and we do a phone follow-up every 6 monthly. So the learning point from this case, first, risk stratifications prior to pregnancy in patients with history of PPCM is very important. Second, close monitoring during pregnancy and at least 1 year after pregnancy may improve outcomes in PPCM patients with subsequent pregnancy. And the last one, we know the importance of family planning counseling include contraceptives. So we need to double check using a special checklist to evaluate our patients' comprehensions, just to make sure that we have the same perspective with our patients. Thank you very much.
Thank you very much. Very interesting case. Dr. Minhas.
Thank you, Dr. Prameswari, for sharing that very fascinating case. I will now be discussing peripartum cardiomyopathy. Thank you, everyone, for joining today. As we know, peripartum cardiomyopathy is a non-ischemic cardiomyopathy traditionally defined as an LV ejection fraction of less than 45%, presenting towards the end of pregnancy or early postpartum months. And there are multiple well-recognized risk factors, which include conditions such as preeclampsia, hypertension, obesity, African-American race, age above 30 years for the mother, and multi-gestational pregnancies. It is important to recognize that peripartum cardiomyopathy is a diagnosis of exclusion, that when we're thinking about patients that come in with heart failure during pregnancy, it is quite possible that that heart failure may have been pre-existing to pregnancy and just be presenting during pregnancy. And some of the conditions listed on this slide should always be in the differential diagnosis when we are meeting patients with heart failure during pregnancy or in the initial months postpartum. There's recently a registry, the ESC EORP registry, looking at 739 women with peripartum cardiomyopathy. So one of the questions that we always struggle as cardiologists, as internists, as obstetricians and gynecologists is whether we can rely on the physical exam or not to detect peripartum cardiomyopathy. As we know, there are multiple symptoms of heart failure that are also somewhat normal symptoms during pregnancy, such as mild peripheral edema that could develop. So in this registry, 40% of women had no peripheral edema during pregnancy and 41% had no pulmonary ralls. I raise this point to bring to your attention that it is important to have high clinical suspicion for heart failure when we are considering this possibility in a patient that is coming in with symptoms that might be suggestive of heart failure. And looking at peripartum cardiomyopathy in particular, at 6 months, the mortality is about 6%, which is not insignificant, with a thromboembolic rate of about 7%, readmission of 10%. And important also to recognize that there is neonatal mortality associated with this condition as well of about 5%. In thinking about the pathophysiology of peripartum cardiomyopathy, so there's likely a genetic predisposition, at least in a subset of women, and we'll discuss in a minute what that might be. But there's activity of cathepsin D, which results in cleavage of prolactin. So prolactin released from the pituitary gland gets cleaved into a 16 kilodalton fragment that then goes on to result in the manifestations of peripartum cardiomyopathy. This slide is important to pay attention to because you'll notice here bromocriptine is the agent that is blocking this prolactin release. There is recognized genetic overlap with dilated cardiomyopathy. So in a study using DNA sequencing from 172 women with peripartum cardiomyopathy, truncating variants were seen in 15%, which is comparable to dilated cardiomyopathy, where 17% had TTN truncating variants. Whether or not this has a clinical effect is to be determined, but more and more evidence seems to suggest that having a TTN truncating variant present in the setting of peripartum cardiomyopathy may in fact have a clinical effect. So you notice in this study a very strong, at least significant difference in the ejection fraction in women that had TTM truncating variant present. So their ejection fraction was 23.5% as compared to 29% in women that did not have this variant present. There's recognized pathogenesis that is shared between preeclampsia and peripartum cardiomyopathy. So both of these conditions present with an imbalance of sFlt1 and PIGF. The prevalence of preeclampsia in peripartum cardiomyopathy is 22%. So to putting that into perspective, this is about 4 times higher than that in the general population, which has a prevalence of about 3 to 5% of preeclampsia, depending on the population that we are looking at. There are some risk factors that portend poor prognosis in peripartum cardiomyopathy. So not entirely unexpected, but the lower the ejection fraction is, the worse that is in terms of prognosis for the woman going forward. The more dilated the left ventricular cavity may be, also portends poor prognosis. And then some interesting, more novel, unique prognostic factors like the TTN truncating variant that can be seen in peripartum cardiomyopathy. Black race is a poor prognosticating factor, as well as having hypertensive disorders of pregnancy. For us as largely adult practitioners, we sometimes do not pay enough attention to the neonatal outcomes that can also be occurring. But when whenever we're talking about pregnant women, we're really talking about a mother and a baby. There are multiple adverse neonatal outcomes that can also be present in peripartum cardiomyopathy, which include things like mortality at its worst, or other conditions like low APGAR scores, prematurity, infant respiratory distress syndrome, or low birth weight. Treatment of heart failure during pregnancy and postpartum should ideally be similar to treatment of heart failure in the non-pregnant state or the non-postpartum state. The unique thing to consider during pregnancy, of course, is any potential teratogenic effect of heart failure medications for the fetus, as well as any potential effect for the baby if the mother is lactating. In general, loop diuretics, beta blockers, hydralazine nitrates, and digoxin have been studied during pregnancy and postpartum during the lactating stage and not found to have any prohibitive side effects. However, medications such as ACE inhibitors, aldosterone receptor antagonists, sacubitril valsartan, and ivabradine do not have enough safety data during pregnancy to be recommended and have mixed safety data during lactation. Unique to peripartum cardiomyopathy, bromocriptine is a dopamine agonist that blocks the release of prolactin, which we discussed is involved in the pathophysiology for peripartum cardiomyopathy. While studies are small regarding use of bromocriptine, they do seem to point towards some benefit of using bromocriptine during pregnancy. So the European Society of Cardiology recommends by level 2B recommendation use of bromocriptine. However, in the United States, we do not have any recommendations regarding the use of bromocriptine for peripartum cardiomyopathy. In general, anticoagulation is recommended while using bromocriptine, given the rise in thrombotic events with this drug. Similarly, one would hypothesize that prolactin levels increase with breastfeeding, stimulate milk production, and might be placing the mother at increased risk if she has peripartum cardiomyopathy, but data from a large cohort, the IPAC cohort, does not demonstrate any adverse outcomes from breastfeeding or myocardial dysfunction. So in general, it is up to the patient and the practitioner to decide whether or not breastfeeding is recommended. And lastly, in terms of talking about subsequent pregnancies, in women that have ongoing myocardial dysfunction, that is, the ejection fraction continues to remain less than 50% postpartum, the European Society of Cardiology guidelines advise against pregnancy. And this is by and large the practice in the United States and around the world as well, that in women that have ongoing myocardial dysfunction, the recommendation is against pregnancy. In women that have had recovery of myocardial function, there is no clear recommendation. Women should be counseled on the possible risks, which include a relapse rate of above 20% that has been described in multiple studies, but mortality has not been described in this population. So this is up to the patient and their provider how they would like to proceed if they have recovered myocardial function. In summary, it is important to recognize that peripartum cardiomyopathy, as well as other cardiovascular conditions that present during pregnancy, require expertise from multiple providers, and that a cardioobstetrics model of care that incorporates expertise from different specialties is important in management of these patients. Thank you.
Thank you, Dr. Sasmaya and Dr. Minhas. I would like to remind everyone to put in their questions on the chat box and for the speakers or panels to answer and discuss the topics on the chat box also. We will continue with the next topic on hypertension in women. The case will be presented by Dr. Patriatna Dewi from Gatot Subroto Hospital, Jakarta, and lecture will be presented by Dr. Anastasia Mihalidu, PhD, joining us from Royal North Shore Hospital, St. Leonard's, Australia. Please.
Thank you, Dr. Yusra, and thank you, JACC Case Report and IWoC for the opportunity to present the case of hypertension in women. The data from Indonesia Basic Health Research in 2018 showed that among adult Indonesians, hypertension occurs in more women than men, with medications compliance also better in women. But although women are more likely than men to be aware of their diagnosis, treatment and control rates remain lower, especially in middle and low-income countries. This is related to both poor access to healthcare and the limited availability or high cost of antihypertensive medications. This is the case of Mrs. TR, 40 years old, with her BMI falls under the overweight categories. She is a housewife with 3 children, and she was referred from primary care facilities with uncontrolled hypertension for almost 15 years. When she first came to our hospital, she complains of headache, blurred vision, tiredness, numbness both hand, and chest pain. She complains no snoring, palpitations, nor sweating. Her high blood pressure started in 2006, shortly after giving birth her second child, and continues to present with BP 150 to 170 over 80 to 90. Her hypertension worsened in the last 7 years with BP 180 over 110. Her medication history are captopril 3 times 50 mg, amlodipine 10 mg, thiazide 50 mg, and bisoprolol 5 mg. She had history of 3 pregnancies, 2 natural deliveries, and 1 C-sections in her 3rd pregnancy due to severe hypertension. She has no history of oral contraceptions, herbs, NSAID, or dietary pills use. She is a non-smoker, no alcohol, has a normal diet, but has a sedentary lifestyle. From family history, her mother and older sister also had hypertension. Her father died at the age of 55 due to acute coronary syndrome, and her youngest brother, still 24 years old, has an episode of hypertensive crisis. Her office BP when she came is 175 over 110. Physical examination was unremarkable. Her ECG showed left ventricular hypertrophy sign. Her blood and urine tests for thyroid, renal, potassium, and urine albumin-creatinine ratio were normal. We did ambulatory blood pressure measurement, and the result of all 24 hours, daytime, and nighttime average confirmed that this patient really had an uncontrolled hypertension. So the problem, that she has a resistant hypertension. Other investigations for these patients were echo showed concentric left ventricular hypertrophy with normal ejection fractions, no co-arc, no diastolic dysfunctions. Her fundoscopy showed hypertensive retinopathy grade 2. Renal ultrasound revealed no abnormal findings. These patients also had cardiac and brain CT for her chest pain and headache complaint, and both results are normal. The abdominal CT scan also showed normal results. So most possible causes of secondary hypertension have already been examined and reveal normal results. We haven't been able to check urine metanephrine level. However, from the abdominal CT scan, showed that she has no signs of adrenal masses or pheochromocytoma. Based on score chart, these patients fall under high-risk categories. So first, we try to maximizing her non-pharmacological measures by dietary modifications, including salt restrictions, and then reducing body weight and increased physical activity. And second, we try to evaluate patients' adherence. Actually, this patient has a relative good adherence, but it would be more ideal if we could simplify her medications by using SPC. Unfortunately, the costs of SPC are expensive and still not covered by our national insurance. And third, optimizing her antihypertensive drugs. Her current meds include candesartan 32 mg, bisoprolol 10 mg, nifedipine 60 mg, clonidine 3 times 150 microgram, and thiazide 50 mg. With these current meds, her home blood pressure measurements still average 140 to 150 over 85 to 90. Our next plan included trying to add spironolactone in her medication regimens, check urine metanephrine level, and we still consider to do the renal CTA or MRA that has higher accuracy, although her renal ultrasound was normal, because the incidence of fibromuscular dysplasia is mostly in young women like these patients. And last, if all the secondary etiologies have been excluded and this is a true resistant hypertension case, we might consider renal naloxone therapy. So the learning points from this case are, first, hypertension not only affect older women, but also can affect in all phases of women's life. from young age, adult, pregnancy, menopause, and elderly. Second, evaluations of resistant hypertension include confirmed treatment resistant, exclude pseudo-resistant, and assess for secondary causes and target organ damage. And the last, patients' adherence and treatment availability play a very important role in managing hard-to-treat hypertension. Thank you very much.
Thank you for
Yes.
the interesting case, Dr. Dewey. And I'd like to take this opportunity to thank the Indonesian Women of Cardiology Steering Committee for this excellent conference, and in particular from the JACC case report Editor-in-Chief, Dr. Julia Graspa. I'm going to cover hypertension in women as a mark of cardiovascular disease. And as we heard, this particular case is a great example of why we need to really focus on hypertension as the primary risk factor. I have no disclosures to report other than to alert people to hypertension. We know that cardiovascular disease is the main cause of death for women. What's interesting is from the Global Burden of Disease study that between the period of 1990 to 2010, there was a decrease in global age standardized prevalence of cardiovascular disease in women. However, in the last 10 years, since 2010, there's been a slight increase. And this is concerning because, as we heard in Dr. Dewey's case, it's not only older women and menopause, as we've continued to hear over the years, but it is younger women. Now, there are many risk factors, and you're all familiar with this diagram from the Lancet Commission report. And in particular, while women share well-established factors like hypertension, dyslipidemia, diabetes, unhealthy diet, physical inactivity is another risk factor. It's important to note that sex-specific risk factors in particular, and there may be a factor here in Dr. Dewey's case, that in terms of hypertensive disorders of pregnancy may play a role, but importantly, there's the under-recognized risk factors which interplay with all of these risk factors, and particularly we need to shine focus on poor health literacy. Women are known consistently over the world, and we don't know why, have lower health literacy than males. There are environmental risk factors which are becoming predominantly now, with air pollution a major concern for all of us, and psychosocial risk factors. Women respond differently and have a major burden in terms of stress, which sometimes is used against us in terms of diagnosis. Now, I don't have to remind this audience that hypertension is the leading cause of cardiovascular morbidity and mortality, but it's a modifiable risk factor. Interestingly, however, you'll see this bottom graph, which is from the Institute of Health and Metrics evaluation. You'll find that in 2009, the primary risk for cardiovascular disease mortality was high systolic blood pressure. Concerningly, over that 10-year period from 2009 to 2019, it still remains the #1 risk factor. We haven't done anything. Despite our efforts, we are continually having a neglected health burden for women with high systolic blood pressure. Why does this matter? Well, because consistently there are more and more studies now, and I'm really pleased that we are focusing more on women's health than we have in the past, but consistently hypertension, particularly in women, is associated with various forms of cardiovascular disease. And I'm just highlighting, in the interest of time, a few of these. And the InterHeart study was looking at which modifiable risk factors were associated with myocardial infarction. And whereas the usual culprits are shown here in terms of diabetes, obesity, hypertension, between men and females, men and women, I should say, hypertension contributed the greatest risk to myocardial infarction, more so in women than in men. And if you notice the numbers, and I'm sorry they're not so visible, even in the control group, the number of hypertensive women was higher than the men. Now, this was explained by saying that they were presented older, but there is increasing evidence coming out, and this is another study that was released, last year, which showed that younger women, with a blood pressure which was stage 1, which isn't all that excessive, between 130 to 139 systolic and 80 to 90 millimeters of mercury diastolic, was associated with a 2-fold increased risk of incident acute coronary syndrome in women during midlife rather than in men. And so there's increasing evidence that we really need to start earlier rather than when women present for menopause. This study, you're probably all aware, was released last year, and I'm delighted to see this because it's actually shows it's the best example of why we need sex disaggregated analyses. For years, we've suffered in terms of identifying differences in women physiology to male because we've lumped it all together and we've done post hoc analysis. This was prospective, and it allowed, doing these analyses allows us great insight to show that while we've assumed that women lag behind men in terms of hypertension by 10 to 20 years, when you actually look at it, they may have lower blood pressure in their before menopause, but in fact, they have a much, and you can see it here, they may have a much steeper increase in blood pressure, which began as early as their 3rd decade of continued throughout their life course. This is not women who've had hypertension disorders of pregnancy. This is tracking women longitudinally, and that's an important message that we really need to start thinking about engaging women in terms of their health and annual blood pressure check. I'd like to share some data that colleagues from Poland and myself found, that this is looking at the blood pressure. When we measure blood pressure, we really need to think about that maybe the arm cuff method may not be the most optimal. And in fact, what we found was that when we measure central or derived measures of central blood pressure, while women, and these were healthy women, while healthy women had lower peripheral and aortic systolic and diastolic blood pressure compared with healthy males, they showed differences in the excess and reservoir pressure, particularly after the age of 51. And so that was an indicator. At that time, we had great difficulty convincing our peers to accept the manuscript, but I'm really pleased that they did, because after that, we are seeing consistently several studies which are showing sex differences in arterial stiffness. And we know that women have different anatomy and different reactivity. And in fact, arterial stiffness might be a much more sensitive indicator for women than it is with men, or I should say than brachial blood pressure, because you may not see those changes. Another factor, which is highlighted from Dr. Dewey's presentation and which I'm conscious about, is racial differences. We've assumed that it'll be the same, but in fact, there are increasing studies which show, particularly this one, that that Black and also different nationalities will have a greater predisposition to adverse effects of arterial stiffness. And so we need to be aware that we need to think differently about how we measure blood pressure, and in particular, how it's an initial marker, as Dr. Grasper asked me to talk about, for cardiovascular disease. We can have a significant impact on reducing the cardiovascular disease mortality in females, but by treating hypertension effectively. And I highlight dementia here, and particularly this study was delighted to find. We all know that hypertension in midlife is a risk factor for dementia. It's a major risk factor because it's the primary cause of death for females in Australia. And as our populations are getting older, it's a tsunami, which is a big concern for all of us. This study looked at early adulthood and also mid-adulthood at much younger ages, which hasn't been shown before. And they followed them up with 2 yearly, I think it was, measures for about 15 years. And what they found was that hypertension was a risk factor for dementia among women starting in their early 40s, but not men. This is huge. Yeah, I know it's one study and we shouldn't really believe it, but it's the start. And I'm really excited that we really have strong signals here that we really should be starting earlier. Hypertension, it came out from our analysis from the Lancet Commission report as the prime target or risk factor to target. We need to do it better. We're not globally, we're not treating hypertension as effectively, but for women, it's critical. I'll just skip on that. And it would be remiss of me not to mention hypertensive disorders of pregnancy. Obviously, I'm not going to go into detail because we had those eloquent presentations earlier. But in fact, what we see is that women with hypertensive disease, or hypertension disorders of pregnancy, have risk not only in increased risk of coronary artery disease, but also heart failure, aortic stenosis, and mitral regurgitation. Likewise, we find, and this was a study that was released last year and showed a very striking association between preeclampsia and the risk of heart failure. And when you have preeclampsia, as we heard earlier from Dr. Minutes, there's shared risk factors, but in fact you have a much more prevalent increase of complications and heart failure. And this was Norwegian data. So in conclusion, I haven't gone into medication because of time constraints, but we need to consider and remember that blood pressure influences cardiovascular disease risk in a sex-specific manner. And we've started to talk about that, but I think we need to all start to engage everybody and our patients about it. And it starts at a lower blood pressure threshold in women than in men. High blood pressure is often referred to as hypertension in men, but in women, it's often mistaken as stress, or if they're older, as menopause, and that's a concern. And I've highlighted this one study, which shows that it's across the life course. And I think Dr. Minnes highlighted, it's not only about the mother, it's also about the children. But in fact, we don't normally think about measuring blood pressure in children if they're healthy, but in fact, this eloquent study showed that high blood pressure in children predisposed to left ventricular hypertrophy in adulthood. And that's a concern because we can prevent it, so we need to start earlier. And finally, I'd encourage all of you to visit the Lancet Commission website and explore. Contribute to it. That's what we need to. And finally, thank you very much for this opportunity.
Okay, great presentations from all speakers. Next up, we're going to hear about a case on MINOCA presented by Dr. Indah Sukmawati from Siloam Hospital, Lipo Village, Jakarta. And lecture on that Dr. Yogesh Jona from University of Chicago, USA. Please.
Thank you. And MINOCA criteria, patient with AMI criteria fulfilled, non-obstructive coronary arteries on angiography, and no specific alternate diagnosis for the clinical presentation. So our case, a 34-year-old woman presented to our ER with a mid-sternal chest pain radiating to her left arm, back, and jaw in the last 3 days. She was diaphoretic at presentation, and her past medical history was unremarkable. No previous record of CVD traditional risk factors was reported, and no pertinent family history of heart disease, stroke, or diabetes. Her blood pressure is 131/87, heart rate was 77, and respiration rate a little bit higher on the 22 to 24 beats per minute. Her lab works showed only a rise in the high sensitivity troponin level, but the other panels is showing a normal limit. So from the ECG, we see there's a T wave inversion in the inferior lead, but otherwise a normal ECG. So we did a bedside echo, which we found a hypokinetic inferior wall with a normal EF. Afterwards, we then do a coronary angiogram for this patient, which we found that she had normal left coronary arteries with a stenosis of 40% in the proximal RCA. So this patient presented with a typical angina with a T-wave inversion in the ECG and abnormal troponin level and regional wall motion abnormalities from the echo. So we diagnosed this patient with an acute MI, and with a non-obstructive coronary arteries, the working diagnosis at the time were MINOCA. So what to do in this type of patient? Firstly, we need to exclude the disorder mimicking AMI and identifying underlying cause of MINOCA. We should do this with an invasive imaging of the coronary arteries, and we can send the patient for CMR. But unfortunately, at that point of time, we don't have these modalities with us. So we try to, as best as we can, to exclude the other possibility of the diagnosis of this patient. So from the clinical presentation, the ECG, the echo, and the lab work, we can exclude most of these diagnoses. So it leaves us with myocarditis and Takotsubo syndrome, which we can actually exclude with CMR when available. And for the plaque disruption, such as plaque rupture, plaque erosion, and eruptive nodule, and also SCAD, we can exclude this with the invasive coronary imaging. But and then for the coronary spasm, if unless it is incidentally occurred during the angiogram, then we need to do a coronary microvascular functional testing. And for the coronary embolism and thrombosis, especially in the young female patient like this, we need to do a thrombophilia screening. And if needed, we can consult to the hematologist so that eventually we can give a cost-targeted therapy, which I believe will be explained at length by the next speaker. So at the point of time, we give the patient a cardioprotective therapy of dual antiplatelet statin and a beta blocker according to the atherosclerosis guideline. So from this case, from this case, we learned that although the coronary arteries do not have any obstructive stenosis, it doesn't mean and doesn't exclude the possibility of AMI, and that we need to extensively evaluate underlying cause of MINOCA with the available resources. And lastly, we need to have a consensus on how to best diagnose and manage MINOCA when local resources do not permit advanced testing as such as this case presented. Thank you.
Thank you, Dr. Indah. Please, Dr. Jana.
Yeah, thanks. All right, hello. My name's Yogesh Jonah. I'm from Chicago, Illinois. I work closely with Dr. Vidovich. I'm a cardiology fellow. I'm really excited to talk to you guys a little bit more about MINOCA over the next few minutes. So myocardial infarction with no obstructive coronary artery disease. I have 5 fantastic cases that really encompass the entire spectrum of disorders that define MINOCA. As our previous presenter kind of talked about, you know, they present with all the same things of a myocardial infarction, from chest pain to abnormal biomarkers. But importantly, we also see the imaging findings consistent with a myocardial infarction. We'll talk a little bit more about those as we get through these. So our first case is of vasospasm. So this is a 60-year-old female with asthma and hypertension who's presented to the hospital with recurrent chest pain over a course of a couple of years that's very responsive to nitro. Her initial cardiac MRI did show infarct pattern in the mid-anterior septal wall, as well as an angiography with only luminal irregularities. And subsequently, a year later, when she came with a similar presentation, she had a new scar in the inferior septum. And so at this point is when we referred the patient, or when the team referred the patient for vasoreactivity testing. So as you can see in these great pictures here, on the left is at baseline and right is after administration of acetylcholine, we see disappearance really of a lot of the smaller branches of coronary arteries, which goes to show you how severe vasospasm can be and how it can really cause an actual myocardial infarction. Our next case is really a great case of stress cardiomyopathy. This was an 86-year-old female who was actually robbed at home in her castle. But immediately after the event, she was taken to the hospital because of chest pain. And as she presented, you know, with troponin elevations, ST elevations, and wall motion abnormalities on the imaging findings, it was consistent with an infarction, and she was sent for angiography. You can see here, however, that the angiography really just showed some minor luminal irregularities, including in the distal RCA. And so she was expectantly managed. And unfortunately, on day 3, this patient passed away of cardiac arrest and wasn't able to be resuscitated. Interestingly enough, she underwent a autopsy, which actually showed that there was a full thickness rupture of the apex, and that was complicated by tamponade. So she had MINOCA that was, caused full thickness myocyte necrosis. And also the autopsy did confirm that she did not have any significant coronary atherosclerosis. Next up, we have a great case that kind of shows why it's important for us to keep investigating these things and figure out what the underlying etiology was. So this is a great case report of a 49-year-old female who's had recurrent anginal chest pain for several years. And, she's had numerous ED visits, numerous angiograms that have all shown no significant atherosclerosis, but she's had multiple MRIs showing different areas of infarction. So she's referred to tertiary care centers. She's had multiple coronary vasoreactivity testings, but finally on her third ACH testing after administration of acetylcholine, you can see what the team noticed was these very clear filling defects in the coronary arteries, which the team used IVUS to confirm that there was no ulcerative plaques or significant atherosclerosis, but in addition, they were able to aspirate these, and cytology showed that they were a kind of loose aggregate of fibrin and platelets. This patient was successfully treated with prasugrel and stayed out of the hospital for years. But it goes to show you the importance for us to continue to investigate these patients and not just lock onto things like spasm, but also less understood ideologies like thrombogenesis. Next up, we have a very classic case of spontaneous coronary artery dissection. This is a 28-year-old female flight attendant who developed chest pain hours into an international flight. And, when she presented to the hospital, she had ST elevations. She underwent angiography, which showed normal coronaries, which is luminal irregularities. But at that time, the ventriculogram and the subsequent echo showed a ballooned apex and a hyperdynamic base, really consistent with Takotsubo. So this patient went on to get an MRI, and that showed infarct pattern in the mid to distal anterior wall wrapping around the apex. And that, given recurrent chest pain and EKG changes, she underwent repeat angiography. And as you can see in this picture here, she had extensive dissection from the left main in the yellow, the blue, the LAD, as well as segments D1 and D2. And ultimately, this patient underwent successful 4-vessel bypass surgery, but it goes to show you, MINOCA can be as serious as requiring bypass. Finally, we have our best case that kind of puts everything together. So this was a 68-year-old female that had sudden onset chest pain, ST elevations upon presentation, as well as imaging findings consistent with Takotsubo, ballooned out apex with the hyperdynamic base. However, when the team did the coronary angiogram, you could see that at segment A was where they noticed a myocardial bridge, and IVUS actually confirmed that through segments B and C, there was spontaneous coronary artery dissection distal to the myocardial bridge. So this patient had this very amazing presentation of all three disease processes: dissection, Takotsubo, and a myocardial bridge that led to her infarct. So in summary, these 5 case reports really encompass the spectrum of underlying etiology, those that we know and those that we're still becoming to understand, that encompass MINOCA. The complications always remain very similar to our classic MI. And really, it's our job as clinical investigators to try to evaluate the underlying etiology and target our treatments there as such. Thank you guys for listening.
Oh, Dr. Vera will present the orthostatic tachycardia syndrome in women. Please, Dr. Vera, time is yours.
Okay. Thank you, Dr. Yusra, and thank you, Dr. Walsh. Thank you to JACC case report and IWoC for the opportunity given to me to present case report about postural orthostatic tachycardia syndrome or POTS in women. POTS is defined as a clinical syndrome of autonomic dysfunction that is usually characterized by frequent symptoms during standing, an increase in heart rate more than 30 BPM when moving from recumbent to standing position, and absence of orthostatic hypotension. The prevalence of POTS approximately 0.2% among 500,000 Americans. Most patients present with POTS between the age of 15 and 25 years, and more than 75% are female. Unfortunately, there is no data on the prevalence of POTS in Indonesia until now. Based on the 2015 HRS expert consensus statement, to confirm POTS diagnosis, it is recommended to perform an orthostatic vital sign and 12-lead ECG recording. As case illustration, we reported 27-year-old female with chief complaint lightheadedness, palpitation, and episode of nerve fainting upon standing from supine position. The pulse recorded on her smartwatch reached 200 ppm. On previous medical history, she was diagnosed with polycystic ovary syndrome and also COVID-19. No family member have similar complaint. A vital sign and physical examination were found to be normal limit unless there was obesity. The result of active standing test showed an increase in heart rate from 70 BPM at 5 minutes after lying down to 135 beats per minute after 8 minutes. And then and we can see here that the blood pressure remains normal. At the time of the examination, she complained of worsening of lightheadedness from supine to standing position. The result of the resting ECG, chest X-ray, laboratory including thyroid function and echocardiography were concluded with the normal finding. From the Holter monitoring recording showed that the basic rhythm is sinus, the average heart rate is 110 BPM, and episode of sinus tachycardia up to 62%. And it did show from her diary that there were frequent complaints of lightheadedness which associated with sinus tachycardia. From this heart rate trend graph, it can be seen that episodes of increment heart rate above 30 BPM are quite frequent, and also several episodes of heart rate more than 120 BPM, which are associated with complaints of lightheadedness. This ECG strip showing an increase in heart rate from 114 BPM to 160 BPM within 10 minutes, which corresponding to her complaints. Based on the investigation that have been performed, the patient was diagnosed as POTS. The treatment given includes adequate fluid intake up to 2 until 3 liters daily and salt consumption of 10 until 12 grams daily. From this case report, there are learning points that can be obtained. First, POTS is often identified as being clinically underdiagnosed and undertreated. A detailed history taking, increased awareness of POTS syndrome, and modest investigation can be done to diagnose POTS. Appropriate management can be given to relieve POTS symptoms and improve quality of life. Thank you very much.
Thank you, Dr. Vera. I think we have run out of time for the live presentation, but there will be a presentation from Dr. Cynthia Monaco and Dr. Antonio Sorgente on POTS, so there will be added to our recording.
Hello, everyone. This is Antonio Sorgente. I'm a cardiac electrophysiologist at the Ardent Management Center at the Universiteit Ziekenhuis in Brussels. And I'm introducing in this presentation Dr. Cynthia Monaco, who is a senior fellows in the same center. First of all, I would like to thank the organizers of this webinar and Dr. Grapsa for this kind invitation. We're going to speak about posterior orthostatic tachycardia syndrome, POTS. As all of you know, this is a disease which is typical of women. If you can go forward with the slide, Cynthia, please. So we're going to give an overview of the definition of the epidemiology and the pathophysiology of POTS. We're going to actually give what could be the differential diagnosis for this kind of disease. And Cinzia will actually give a very good advice about what could be done with a pharmacological treatment, but above all, will present the innovative approach which has been started in our hospital and which has already given very good results. So I will let Cinzia introduce and talk about this interesting syndrome, and hope you can enjoy it. Please, Cinzia.
Thank you, Antonio, for the introduction, and thank you for the opportunities to all the organizer of this Congress, especially to Dr. Grapsa for the opportunity. Postural orthostatic tachycardia syndrome is a systemic disease with no specific symptoms, and postural tachycardia is only one of several criteria implemented for the diagnosis. Clinical symptoms such as dizziness, palpitations, or gastrointestinal symptoms can coexist in these patients. And the most affected population group is young women aged between 20 and 40 years old. These women often presented first symptomatology presyncope and less common syncope. What normally happens with the transition to the orthostatic position is that the decreased venous return and the stroke volume the decreased stroke volume can activate the arterial baroreceptors with a consequent compensatory vagal withdrawal and sympathetic activation that resulting in an increasing of the heart rate and the heart contractility. These normally produce a small decrease in systolic blood pressure and a small increase in diastolic blood pressure. What happens in the predisposed individuals that are affected by POTS is that the sympathetic activation in upright position leads to a major increasing in the heart rate and a major decreasing of the systolic blood pressure, accompanied by a decreasing in the gastrointestinal motility, and over time a vicious circle is established that leads to cardiovascular deconditioning. Women have an higher heart rates on average, and also lower stroke volumes in their physiology, and this baseline condition potentially making them more susceptible overall to this condition. And there are also other studies already done that suggested that also the differences in the hormonal activity between the female and male can accompany this process in the female population. There are many hypotheses about how POTS is developed, and not everyone agrees that the process is triggered by an increasing in the heart rate. That is one of the theory that we support. The heart rate can drive all the process, all the symptomatology, and all the symptoms that the patient affected by POTS have. Of course, as previously described, here we can see the coexisting condition and the differential diagnosis that incorporate all the syndrome that can have, as previously said, that can have a increasing of the heart rate. So inappropriate sinus tachycardia, or orthostatic hypotension, anxiety, of course, or the neurocardiogenic syncope. Regarding the evaluation of the disease, the medical history represents, of course, one of the crucial points, and followed by clinical and instrumental investigation such ECG or alter monitoring, loop recorder implantation, and in some occasion also the tilt table test. We can see that the history of the patient and the physical exam with orthostatic vital signs are in class first of the recommendation. And according to the guidelines, the treatment recommendations focus primarily on lifestyle changes, so exercise and increased fluid intake, and the possibility of drug treatment with medicaments like fluorocortisone, pyridostigmine, or propranolol at low doses, and in patients who have prominent hyperadrenergic tone, also clonidine or alpha-methyl-dopa. The management can variate in base of what is the major symptomatology in this patient. Of course, if the symptoms are dominated by palpitation, we have to consider to decrease the activity of the sinus node, so we consider ivabradine or non-selective beta blockers. Of course, we can say that post-treatment can be difficult, can be tricky. There are no approaches that are consistently effective, and a mixture of intervention is often required. Also because few therapies have been studied with the randomized controlled trials, and what we propose, the sinus node sparing novel hybrid approach, that is the treatment that we are following in our center, is not recommended as first approach due to the possible occurrence of adverse event, but is something that can represent a valid alternative in patients that don't respond to the conventional treatments. Why we are focus our attention on the sinus node? Because some anatomic pathological studies in past have shown that migration during the embryonic period of the sinus node, of course, is composed of specialized pacemaker cell, can involve a migration of this cell not only in the sinus node region but also in other regions, like the superior vena cava or the crista terminalis or the epicardial side of the heart. And this is a schema of the modulation of the node that that we are performing in our center. So the gray line on the left side of the figure shows the line that we perform with the radiofrequency ablation. So at the connection between the right atrium and the superior vena cava, at the connection with the inferior vena cava and the crista terminalis line. The advantage of a minimal invasive approach, especially in this syndrome in which the ablation treatment is not the first therapeutic choice, is shift the balance in favor of the benefit over the possible complications. For example, the right phrenic nerve that passes along the pericardium lateral to the superior vena cava, and that can, of course, be injured during the endocardial sinus node modulation. It is a procedure that is performed in many centers. With the hybrid ablation, so the right chest is accessed with the 3 working ports, and we work both endocardially and epicardially. So endocardially, we perform the map, and in baseline, we perform an activation map to visualize the position of the sinus node that in generally is located in a standard position. And here we can see in this view the activation, the first activation that actually doesn't involve just the sinus node region, but is very wide along the right atrium. The next step is to perform the radiofrequency ablation that we perform with a bipolar bidirectional radiofrequency clamping device that we use to deconnect the superior and the inferior vena cava, and an ablation of the crista terminalis line that it can be performed with the clamping or with a linear RF ablator. After the ablation, we have the activation of the right atrium is completely changed, or what I mean is that of course, the earliest activation is remains in the sinus node, but the extension of the activation is not involved anymore. The crista terminalis doesn't involve the inferior and the superior vena cava. And in the left panel, we can see the voltage map that clearly show a scar along the crista terminalis and along the two veins. The other tissue of the right atrium, of course, remains healthy tissue. These are two of the papers that we proposed about the sinus node sparing hybrid approach, and this is our experience. So we have a population, we already published a population of 50 patients with both inappropriate sinus tachycardia and POTs. As you can see, the majority of the population were represented by women with a very young age. 22 years old was the average age, and these are our results. So we had decreasing in the heart rate, especially during the rest and during the night. That is a moment in which this patient more suffer about the symptomatology of the high heart rate condition. The complication that we have are especially connected to the approach. So we have pericarditis because, of course, we have to access the pericardium to have have the possibility to access to the epicardial surface of the heart. And so these are our reference that we use for this presentation. I want to thank you to Antonio and again to all the organizers of this Congress.
Thank you very much.
I want to thank again this outstanding panel. We heard cases from Indonesia and the issues faced in managing such cases. We then learned from quick and concise lectures on how to manage peripartum cardiomyopathy, hypertension in pregnancy, how to diagnose and do cause-targeted therapy, MINOCA, and about POTs in women. We also heard from renowned experts on their take on the issue. Dr. Walsh?
So yeah, thank you very much, Dr. Yusra. I want to thank all of our panelists and all the attendees for joining us today. This was really an important webinar and really exploring a lot of areas that we don't know enough about in women's cardiovascular health. So thanks to everyone, but most importantly, I think thanks to Dr. Julia Grapsa, the Editor-in-Chief of JACC case reports, for organizing this with the Indonesian women in cardiology. And just as a postscript, we did during our planning sessions hope that we will all meet together sometime in the future in person. And I think we thought it might be in Bali. So we really look forward to that. And thanks again to everyone for all of your important content and education.
Okay, thank you, Dr. Walsh. Thank you for all panelists and the attendees. Thank you.